In this informative video, we delve into the crucial topic of hospital infection control and prevention policies. Join us as we explore the key measures and protocols implemented in healthcare settings to ensure patient safety and minimize the risk of infections. Discover the essential practices followed by healthcare professionals to maintain a clean and sterile environment, including hand hygiene, proper disinfection techniques, personal protective equipment, PPE, usage, and more. Whether you're a healthcare worker, patient, or simply interested in healthcare practices, this video provides valuable insights into the importance of infection control and prevention policies in hospitals.
HIC 01, Part 1, Hospital Infection Control and Prevention Program. Infection Control. Hospitals recognizes the control of healthcare-associated infections, HAI, as an important issue and is committed to fulfilling its responsibility by ensuring that proper safeguards are instituted to identify and prevent HAI. All aspects of hospital function are included in this activity. Definition of healthcare-associated infection. Any clinically recognizable microbiological disease that affects the patient as a consequence as being admitted to hospital, or attending for treatment, or the hospital staff as a consequence of their work, whether or not the symptoms of a disease appear while the infected person is in the hospital. Purpose: 1. To maintain standards in infection control measures and minimize hospital-acquired infections in patients and employees. 2. To define policy and procedure regarding healthcare-associated infections in the hospital. Introduction. Infection. Infection is the invasion and multiplication of microorganisms. Infection Control Team. The Infection Control Team plays a major role in the prevention and control of nosocomial infections. Infection Control Program. Hospital has documented infection prevention and control program which aims at preventing and reducing risk of healthcare-associated infections. The Infection Prevention and Control Program is a continuous process and updated in every year. Hospital Infection Control Committee. The hospital have an Infection Control Committee which coordinates all infection prevention control activities. Hospital Infection Control Committee members are as follows. 1. HICC Managing Director Senior Surgeon. 2. Senior Consultant, Physician. 3. Nursing in Charge. 4. Infection Control Nurse. 5. Pharmacy in Charge. 6. Housekeeping Supervisor. 7. Lab in Charge. Aims of the HICC. The aim of HICC is to improve hospital infection control practices and to prevent or minimize the potential for nosocomial infections in patients, relatives, and healthcare providers. Activities of Infection Control Team. 1. The hospital has an Infection Control Team, which coordinates implementation of all infection prevention and control activities. 2. The team is responsible for day-to-day functioning of infection control program. 3. Periodical training of all category staff about infection control protocols and policies. 4. Establish standard operational procedures for infection control practices. 5. Introduce new policies and protocols on the method of disinfection and sterilization. 6. Maintain and implement biomedical waste management protocols. 7. Regular monitoring of engineering department and water supply system. 8. Supervision of biomedical waste management activities. 9. The surgeon is designated as Infection Control Officer, ICO, in hospital. 10. Hospital has a designated Infection Control Nurse, ICN, based on training and experience. Responsibility of Infection Control Nurse. 1. maintaining records and statistics regarding IC activities and maintains HAI incidents record. 2. Checking by inspection that infection control and prescribed disinfectant procedures are being carried out in accordance with hospital policy. 3. Checking of housekeeping activities like the use of personal protective equipment's usage of proper disinfectant, mopping plan, and biomedical waste management. 4. Training of all category staff. 5. Liaison between laboratory and ward staff, informing head of department and giving advice on infection control problems. 6. Notification of communicable diseases and other notifiable disease through telephone and as well as through email. 7. Arrangements taken to provide hand washing solutions and alcohol-based hand rubs. 8. Work as a clinical supervisor by ensuring all the established policies and protocols are practiced like hand washing procedures, use of hand rubs, isolation policies, care of fore and vascular access, urinary catheters, universal precautions, housekeeping, cleaning and disinfection, PPE, equipment cleaning, etc. 9. Ensure health checkup of all employees. 10. Monitoring engineering activities like maintenance of AquaGuard registers and cleaning register of water tanks, etc. 11. Immediate attentions in NSI and post-exposure prophylaxis. HIC-01, Part 2, Hospital Infection Control Policies and Procedures. High Risk, Critical Areas. Hospital identified various high-risk areas and procedures, and has policies to prevent infection in these areas. High-risk areas of the hospital are identified as 1. Operation theatres. 2. Intensive care units. 3. Casualty. 4. Labor room. Concept of standard precautions. There are a number of precautions designed to protect healthcare workers from exposure to blood-borne pathogens. While majority of patients infected with HIV, PSC, HCV are asymptomatic at the time of presentation, all patients are considered as having potentially infectious blood and body fluids. Precautions may vary based on anticipated exposure. Features of universal precautions. 1. Use of personal protective equipments. A. Mask protection from airborne infections or situation which lead any splash or sprays of blood and body fluid. B. Glove use glove when we are touching the hand with blood and body fluids, secretions, any wound, or any other contaminated items. C. Apron any chances of splash or contamination on soiling. D. Goggles during positive cases, OT and LR. E. Boots if necessary. F. Caps are worn whenever indicated. 2. Prevention of injury with sharps. Sharps injuries commonly occur during use of needles and surgical instruments and after use during disposal. Precautions to be observed. A needles should not be recapped, bent or broken by hand. B. Disposable needles and other sharps should be discarded into puncture-resistant containers at the site of procedure. C. Sharps should not be passed from one HCW, healthcare worker, to another. The person using the equipment should discard it. If necessary, a tray can be used to transport sharps. D. All sharps containers to be discarded when 3/4 full. 2. Hand washing. Hand washing means vigorous rubbing of hand with soap and water or with any antiseptic agents. Most common mode of transmission of pathogens is via hands. Hand washing is the single most important means of preventing the spread of infection. A. Types of hand washing. 1. Social hand wash. 2. Procedure hand wash. 3. Surgical hand wash. B. Purpose of hand washing. 1. To remove dirt and debris. 2. To decontaminate the hands. 3 to prevent cross-infection. 4 to break the chain of infection. C. When to wash hands. 1 before and after duty. 2 before each invasive procedure. 3 before and after using gloves. 4 after touching of blood or body fluid. 5 before and after touching patients. 6 before touching invasive devices. 7 after toileting, urination. D. Indications for hand hygiene. 1 When hands are visibly dirty, contaminated, or soiled, wash with non-antimicrobial or antimicrobial soap and water. 2 If hands are not visibly soiled, use an alcohol-based hand rub for routinely decontaminating hands. E. Specific indications for hand hygiene. Before. A. Patient contact. B. Donning gloves when inserting a CVC. C. Inserting urinary catheters, peripheral vascular catheters, or other invasive devices that don't require surgery. After. A. Contact with a patient's skin. B. Contact with body fluids or excretions, non-intact skin, wound dressings. C. Removing gloves. Social hand washing, 10 to 15 seconds. Indications. 1 Before handling food. 2 After visiting toilet. 3 Before and after nursing the patient, bathing and bed making. 4 It can be used in community and public places. Procedure hand washing or hygienic hand washing, 30 seconds to 1 minute. Indications. 1 Before each invasive procedure. 2 Before attending immunocompromised patients. 3 Before and between caring for high-risk patients. 4 Before and after use of gloves. 5 After touching of blood or body fluid. Methods of procedure hand washing. 1 Wet hands with running water. 2 Obtain soap or detergent that contains antimicrobial agents spread all area of the hands. 3 Vigorous rubbing of hands, all area, about 30 seconds to 1 minute. 4 Wash hands thoroughly with running water. 5 Rinse and dry. 6 Turn off water with using paper towel or use elbow to close the tap handle. Steps of procedure hand washing. 1 Palm to palm. 2 Right palm over left dorsum and left over right dorsum. 3 Palm to palm finger interlaced. 4 Back of finger to opposing palms with finger interlocked. 5 Rotational rubbing of right thumb clasped in left palm and vice versa. 6 Rotational rubbing, backwards and forwards with clasped fingers of right hand in left palm and vice versa. 7 Rotational rubbing of right wrist and vice versa. Dry thoroughly. Surgical hand wash, 3 to 5 minutes. Indications of surgical hand washing. 1 Prior to all operative procedures. 2 Prior to treatment of all burns cases. 3 Before insertion of all invasive devices, cardiac catheterization, insertion of all lines especially arterial and central venous catheterization. Method of surgical hand washing. 1 Hands are washed up to the elbow freely using disinfectant. 2 Scrubbing of fingers, space between fingers and nails, brush used to scrub the nails. 3 Wash hands thoroughly with running water, after wash the tap should be closed with elbow. 4 Keep the hand finger upright position. 5 Dry the hand with sterile towel. Hand rub. In chlorhexidine with a 70% alcohol hand rub in all areas. When? 1 Before touching invasive devices. 2 After touching the patient. 3 Before handling the patient. 4 Before preparing any injections. HIC-01, Part 3, Hospital Infection Control Policies and Procedures. Safe Injection and Infusion Practices, SAFE-I. A safe injection, Lancet procedure or intravenous device insertion is one that A. Does not harm the recipient. B. Does not expose the provider to any avoidable risk. C. Does not result in any waste that is dangerous for other people. Purpose. The purpose of SAFE-I is to promote implementation of safe practices associated with the following medical procedures. A. Intradermal, subcutaneous and intramuscular needle injections. B. Intravenous infusions and injections. C. Lancet procedures. General safety practices. This section describes the following practices that are recommended to ensure the safety of injections and related practices. A. Hand hygiene. B. Gloves where appropriate. C. Other single-use personal protective equipment. D. Skin preparation and disinfection. A. Hand hygiene. Perform hand hygiene before A. Starting an injection session, i.e. preparing injection and giving injections. B. Coming into direct contact with patients for healthcare-related procedures. C. Putting on gloves. First make sure hands are dry. After A. An injection session. B. Any direct contact with patients. C. Removing gloves. Key elements, indications, precautions. Hand hygiene. Hand washing or alcohol-based hand rub. Hand hygiene before and after contact with every patient is the single most important means of preventing the spread of infection when hands are visibly dirty or contaminated with proteinaceous material. Wash them with antibacterial or plain soap and running water. Then dry them using single-use paper towels when hands appear clean, not visibly soiled. Clean them with an alcohol-based hand product for routine decontamination, then dry them using single-use paper towels. Do not use alcohol-based hand products when hands are visibly soiled. Do not use alcohol-based hand products after exposure of non-intact skin to blood or body fluids. In such cases, wash hands with antibacterial or plain soap and running water, then dry them using single-use paper towels. B. Gloves where appropriate. Staff at hospital, who are in direct contact with patients, shall wear non-sterile, well-fitting latex or latex-free gloves when coming into contact with blood or blood product. Indications for glove use in injection practice are: key elements, indications, precautions. Glove use where non-sterile, well-fitting, single-use gloves, when there is a likelihood of coming into direct contact with a patient's blood or other potentially infectious materials, for example body fluids, moist body substances and saliva, in dental procedures, mucous membranes and non-intact skin when performing venipuncture or venous access injections, because of the potential for blood exposure at the puncture site if the health worker's skin is not intact, for example through eczema, or cracked or dry skin, when undertaking injections. Do not use gloves. A. For routine intradermal, subcutaneous and intramuscular injections. B. If the health worker's skin is intact. C. If the patient's skin is intact. Gloves do not provide protection against needle stick or other puncture wounds caused by sharp objects. Needles, scalpels and other sharps should be handled with extreme caution. C. Other single-use personal protective equipment. Masks, eye protection and other protective clothing are not indicated for the injection procedures unless exposure to blood splashes is expected. When using single-use personal protective equipment, dispose of the equipment immediately after use. D. Skin preparation and disinfection. To disinfect the skin, use the following steps. 1. Apply a 60-70% alcohol-based solution, isopropyl alcohol or ethanol, on a single-use swab or cotton wool ball. Do not use methanol or methyl alcohol as these are not safe for human use. 2. Wipe the area from the center of the injection site working outwards, without going over the same area. 3. Apply the solution for 30 seconds, then allow it to dry completely. Injection devices. The management of hospital shall ensure that an adequate supply of single-use devices is available, to allow providers to use a new device for each procedure. 1. Practical guidance on use of injection devices. When using a sterile single-use device, A. Use a new device for each procedure, including for the reconstitution of a unit of medication or vaccine. B. Inspect the packaging of the device to ensure that the protective barrier has not been reached. C. Discard the device if the package has been punctured, torn or damaged by exposure to moisture, or if the expiry date has passed. 2. Medication. I. When giving medication, A. Not use a single loaded syringe to administer medication to several patients, i.e. ensure one needle, one syringe, one patient. B. Do not change the needle in order to reuse the syringe. C. Do not use the same mixing syringe to reconstitute several vials. D. Do not combine leftover medications for later use. Single-dose vials whenever possible. Use a single-dose vial for each patient, to reduce cross-contamination between patients. 3. Multi-dose vials. A. Please remember, only use multi-dose vials if there is no alternative. Open only one vial of a particular medication at a time in each patient care area. If possible, keep one multi-dose vial for each patient, and store it with the patient's name on the vial in a separate treatment or medication room. Do not store multi-dose vials in the open ward, where they could be contaminated with spray or spatter. B. Discard a multi-dose vial. A. If sterility of content is compromised. B. If the expiry date or time has passed, even if the vial contains antimicrobial preservatives. C. If it has not been properly stored after opening. D. Within 24 hours of opening, or after the time recommended by the manufacturer, if the vial does not contain antimicrobial preservatives. E. If found to be undated, improperly stored, inadvertently contaminated or perceived to be contaminated, regardless of expiry date. Preparing injections. Injections should be prepared in a designated clean area where contamination by blood and body fluids is unlikely. Practical guidance on preparing injections. 3 steps must be followed when preparing injections. 1. Keep the injection preparation area free of clutter so all surfaces can be easily cleaned. 2. Before starting the injection session, and whenever there is contamination with blood or body fluids, clean the preparation surfaces with 70% alcohol, isopropyl alcohol or ethanol, and allow to dry. 3. Assemble all equipment needed for the injection. O. Sterile single-use needles and syringes. O. Reconstitution solutions such as sterile water or specific diluent. O. Alcohol swab or cotton wool. O. Sharps container. A. Labeling. After reconstitution of a multi-dose vial, label the final medication container with date and time of preparation, final concentration, expiry date and time after reconstitution, name and signature of the person reconstituting the drug. For multi-dose medications that do not require reconstitution, add a label with date and time of first piercing the vial, name and signature of the person first piercing the vial. Administering injections. An aseptic technique should be followed for all injections. Practical guidance on administering injections. A general. Check the drug chart or prescription for the medication and the corresponding patient's name and dosage. Perform hand hygiene. Wipe the top of the vial with 60–70% alcohol using a swab or cotton wool ball. Open the package in front of the patient to reassure them that the syringe and needle have not been used previously. Using a sterile syringe and needle, withdraw the medication from the ampoule or vial. B. Reconstitution. If reconstitution using a sterile syringe and needle is necessary, withdraw the reconstitution solution from the ampoule or vial, insert the needle into the rubber septum in the single or multi-dose vial and inject the necessary amount of reconstitution fluid. Mix the contents of the vial thoroughly until all visible particles have dissolved. After reconstituting the contents of a multi-dose vial, remove the needle and syringe and discard them immediately as a single unit into a sharps container. C. Delay in administration. If the dose cannot be administered immediately for any reason, cover the needle with the cap using a one-hand scoop technique. Store the device safely in a dry kidney dish or similar container. D. Important points. Do not allow the needle to touch any contaminated surface. Do not reuse a syringe, even if the needle is changed. Do not touch the diaphragm after disinfection with the 60–70% alcohol, isopropyl alcohol or ethanol. Do not enter several multi-dose vials with the same needle and syringe. Do not re-enter a vial with a needle or syringe used on a patient if that vial will be used to withdraw medication again, whether it is for the same patient or for another patient. Prevention of sharps injuries to health workers. Use of best practices can help to prevent sharps injuries to health workers. Practical guidance on prevention of sharps injuries. To avoid sharps injuries. 1. Ensure that the patient is adequately prepared for the procedure. 2. Do not bend, break, manipulate or manually remove needles before disposal. 3. Avoid recapping needles, but if a needle must be recapped, use a single-handed scoop technique. 4. Discard used sharps and glass ampoules immediately after use in the location where they were used, disposing them into a robust sharps container that is leak and puncture resistant. 5. Place the sharps container within arm's reach, preferably in a secured area, to allow for easy disposal of sharps. 6. Seal and replace sharps container when the container is 3/4 full. HIC-01, Part 4, Hospital Infection Control Policies and Procedures. Precautions against airborne transmission. These precautions are designed to reduce the risk of airborne and droplet transmission of infectious agents, and apply to patients known or suspected to be infected with epidemiologically important pathogens that can be transmitted by these routes. Components of respiratory isolation. Place the patient in a single, private room with closed doors. Patients with same illness, but no other infection, can be cohered in one room. Masks to be worn by those who enter the patient's room. Susceptible persons should not enter the room of patients known or suspected to have measles or varicella, chicken pox. Gowns are not routinely necessary. Use gowns if soiling is likely. Gloves are necessary while handling patients. Hand must be washed after touching the patient or potentially contaminated articles and before taking care of another patient. Articles contaminated with infective material must be discarded or bagged and labeled before being sent for decontamination and reprocessing. Precautions against contact transmission. Contact isolation precautions are recommended for specified patients known or suspected to be infected or colonized with epidemiologically important microorganisms that can be transmitted by direct contact with the patient, hand or skin-to-skin contact that occurs when performing patient care, or indirect contact, touching, with contaminated environmental surfaces or patient care items. Components of contact transmission. 1 Gowns are indicated if soiling is likely. 2 Gloves are indicated for touching infected material and area. 3 Hands must be washed after touching the patient or potentially contaminated articles and before taking care of another patient. 4 When possible, dedicate the use of non-critical patient care equipment to a single patient or cohort of patients infected or colonized with the pathogen, requiring precautions to avoid sharing between patients. If use of common equipment or items is unavoidable, then adequately clean and disinfect them before use for another patient. 5 Articles contaminated with infective material must be discarded or bagged and labeled before being sent for decontamination and reprocessing. Precautions against bloodborne transmission. 1 Instruction for wards. Admission. Patients with HIV, HBV, HCV disease but presenting with unrelated illnesses may be admitted in any ward as per existing rules. Confidentiality shall be maintained with appropriate precautions to prevent nosocomial transmission. Preparation of patient. It is the responsibility of the attending physician to ensure that patients testing positive are informed about the result and receive counseling. The nursing staff will explain to patients, attendants and visitors, when necessary, the purpose and methods of hand washing, body substance and excreta precautions, and other relevant precautions. Red bag, reusable non-sharp material. The ward sister must ensure that the prescribed bag is obtained from CSSD when a patient with HIV, HBsAg or HCV infection is admitted. All contaminated items that are to be sent to CSSD for disinfection are placed in the bag and sent for autoclaving. Sharps are not to be discarded in the red bag. Linen and procedure trays to be sterilized separately. HIC-02 Prevention of Hospital-Acquired Infection, HAI. Hospital-acquired infections are infection acquired during or as a result of hospitalization, generally after 48 hours of admission. It can manifest even after discharge. Cleaning protocols. 1 Mopping plan, clean to unclean area. Mopping plan means cleaning done from clean area to unclean area. It gives special information to cleaning staff about priority of cleaning. Mopping plan contains 4 categories. The order of cleaning is: A. Immunocompromised patient's room. B. Room of the patient with clean case, clean room. C. General. D. Infected. If there is a patient with communicable disease, that room should be cleaned in the last, irrespective of plan. Direction will be given by the head nurse, sister staff nurse on duty, housekeeping supervisor, HIC nurse. 2. Environment. Clean the floors with a disinfectant thrice a day. Clean with soap solution first and then with super shine solution 3 times a day. Wash the floors with soap and water and disinfecting solution using scrubbing machine once in a week. Do not carry out any cleaning activities while 1. Sterile supplies are being handled. 2. Sterile procedures are in progress. A. Use 1% sodium hypochlorite solution to clean environment surfaces if contamination with blood and body fluids occur. B. Use 1% sodium hypochlorite solution for 30 minutes for disinfecting mops used for cleaning blood. C. Detach the pads and brushes of scrubbing machine after each use, clean thoroughly and dry. D. Clean the walls and ceilings weekly and on transfer, discharge, death of a patient. 3. High-risk areas. A. Floors are cleaned with prescribed disinfectant 5 times a day with super shine 2% or equivalent. B. Ventilator parts are cleaned with prescribed disinfectant. C. All equipment including monitor are cleaned with prescribed disinfectant spray. D. Some plastic items like ambu bag, ventilator tubing, O2 mask, nebulization set are sterilized by formalin gas, generally ETO sterilization recommended. Implement the same. E. Change the HEPA filter, ventilator, every 72 hours. F. Keep a disinfectant hand rub solution in each bedside. G. Keep separate stethoscope, BP always ready to use with a standby. H. Damp dust bed frames, railings, IV stands, lockers etc. daily with prescribed disinfectant. I. Floor cleaning done 4 times in a day with prescribed disinfectant. J. Cover the mattresses and pillows with waterproof covers. K. Use disposable plastic sheets or Macintosh to protect the bed linen. L. Disinfect the patient's unit with prescribed disinfectant solution after the transfer, discharge or death. M. Check the expiry date of CSSD items every day. 4. Wards. A. Damp dust the bed frames, railings, IV stands, lockers etc. daily with prescribed disinfectant. B. Floor cleaning done 3 times a day from clean area to unclean area. C. Cover the mattresses and pillows with waterproof cover. D. Use disposable plastic sheets or Macintosh to protect the bed linen. E. Disinfect the unit with prescribed disinfectant after the discharge, transfer or death of a patient. Fumigate the room after the transfer, discharge, death of an infected patient with super shine or equivalent. Fogging, fumigation. This method of disinfection is used after discharge of a patient with communicable diseases or before admitting a patient after high-risk operation. Action time 45 minutes to 1 hour. Mode of use 11% hydrogen peroxide plus 0.01 silver nitrate in water, 800 ml water and 200 ml solution. Room should be kept closed for 2 hours. Disinfection and cleaning of equipments. 1. BP apparatus and stethoscope clean properly with Sprit daily basis. 2. BP apparatus cuff wash thoroughly with soap and water and dry it properly. Wash and dry the BP cuff if used for an infected patient after the discharge. Weekly clean if used for an infected patient after the discharge. 3. Digital thermometer clean properly with Sprit or ethanol 70% daily, and after the use of every patient. 4. Glucometer clean properly with Spirit daily. 5. Dressing trolley clean with Super Shine. Keep the store solutions in their original bottles. Avoid refilling to smaller bottles. Repeat daily. 6. Steel tray wash with soap and water daily. 7. Measuring tape and torch clean properly with Spirit daily and when required. 8. Nebulizer clean properly with Spirit daily. 9. O2 flow meter. Wash with soap and water weekly. After each use of patient, change sterile water every day. 10. Suction apparatus. Empty the bottles in every week or when required. Scrub with soap and water. Disinfect with 1% sodium hypochlorite solution. Weekly and after each use. 11. Infusion pumps and monitors clean with Super Shine daily, after the use of every patient. 12. Refrigerator defrost and wash with OAP and water weekly. 13. Laryngoscope blades. Detach the blades. Wash with soap and water, clean with Spirit daily and after the use of every patient. 14. Weighing machine clean with soap and water daily. 15. Electronic weighing machine clean with Super Shine daily. 16. Telephone clean with Spirit daily. 17. Ventilator rinse and disinfect the expiratory channel with Spirit humidifier to be cleaned with water and then to be disinfected with Codex for 3 to 6 hours. Rinse with sterile water and dry before replacing. Disinfect the transducer with 70% alcohol. About 1 hour. Silicone tubing are used after ETO. Change the bacterial filter, home, every 72 hours or when required. Expiratory and inspiratory filters are sent to CSSD for plasma sterilization. Attach one bacterial filter to the expiratory port if used for an infected patient after each use of the patient. 18. Patient trolley and wheelchairs clean with soap and water daily. 19. Steam inhaler wash with soap and water daily. 20. IV stand clean with soap and water daily. 21. Defibrillator and monitor. Use a clean cotton swab, moist with alcohol, 70 to 99% isopropyl alcohol, ethyl alcohol, or methylated spirits, daily. 22. Pulse oximeter clean with spirit daily. 23. Airway use disposable airways for each patient. Scrub with soap and water daily and when required, discard after discharge or death of the patient. After each use. 24. ET. Tubes. Tracheostomy tubes. Use disposable ET and tracheostomy tubes. Refer equipment related protocol number 4. 25. Oxygen mask, nasal cannula. Use fresh mask and cannula for each patient's use. Clean with alcohol when required. Don't reuse nasal cannula after each use. 26. Ambu bag and mask. Detach the parts. Wash with soap and water. Send to CSSD for ETO. Disinfect the ambu bag with hypochlorite 1% solution for 10 hours for infectious cases and send to CSSD. After each use. 27. Proctoscope clean with spirit. Clean with soap and water. Sent to the CSSD for sterilization. After each use. 28. ECG and transducer cables clean with spirit daily. Wash and dry the BP cuff if used for an infected patient after the discharge. Wash BP cuff weekly. After each use. 29. Bedpan, measuring jar, commode clean properly with soap and water. Immerse in 1% antiseptic solution for 45 mts. Solution to be changed every week. 30. Urinal and sputum mug disposable. 31. Endoscopes. Glutaraldehyde after each use. Laundry and linen management. All used linen shall be considered contaminated and shall be bagged at the location of use before being taken to laundry. A soiled linen. Soiled linen shall be collected in the designated container and taken to laundry. Designated container shall be covered during transport of soiled linen. Cloth liners, containers shall be washed daily. Dirty utility room shall be swept daily and washed, mopped with a detergent/disinfectant weekly and whenever visibly soiled. Soiled linen shall be handled as little as possible and with minimum agitation, in order to prevent gross microbial contamination of the air and of persons handling the linen. All soiled linen shall be bagged at the location of use. Soiled linen shall not be sorted in patient care areas. Bags containing soiled linen shall be tied before being taken to laundry in order to prevent spillage. All linen that is contaminated with blood, excreta or other body fluids shall be placed in designated laundry bags. Personnel shall wear protective clothing, including gloves and gowns, aprons, when handling soiled linen. Employees collecting linen at the laundry shall also wear heavy-duty gloves and a gown. Hands shall be washed after gloves are removed. Staff shall be instructed in the principles of personal hygiene, including frequent hand washing. Clean linen. Hand washing for 10 to 15 seconds, with attention to nails and areas fingers is mandatory before handling clean linen. Clean linen shall not be handled more than necessary in order to minimize contamination. Any linen dropped shall be considered soiled. Covered linen carts shall be used to transport clean linen to the units. Clean linen shall be stored in a clean, dry area. Facilities. Hand washing facilities are available to all employees in the linen area. Barriers to protect employees from blood, body fluids, secretions and excretions are located in the laundry area. Employees shall be informed of the location and of barriers at the time of orientation to the unit. Carts must be cleaned before transporting clean linen. Patient linen. Bed linen is to be changed daily and whenever soiled with blood or body fluids. Patient's gown is to be changed every day and whenever soiled with blood or body fluids. Dry dirty linen is to be sent to the laundry for regular wash. Engineering controls to prevent infection. Hospital adopts appropriate engineering control to prevent infections. 1. The hospital patient care areas are designed in such a manner to ensure optimum bed spacing. 2. Operating rooms are provided with HEPA filter, to ensure double filtration of air. 3. Periodical checking of water resources. 4. Periodical checking and maintenance of equipments, AC ducts, AHUs, replacement of filters. 5. Periodical checking, replacement or repair of plumbing and sewer lines. 6. Machinery and equipment should be checked, cleaned and repaired routinely. 7. Urgent repairs should be carried out at the end of the day's list. 8. Air conditioners and suction points should be checked, cleaned and repaired on a weekly basis. 9. Preventive maintenance on all theatre equipment to be carried out weekly and major work to be done at least once every year. OT, air changes per hour. 1. Air change per hour. A. All the general OTs of hospital are installed with laminar flow system so as to maintain air exchanges. All these OTs have a minimum 5 to 10 air exchanges per hour and not more than 25 per hour. B. The fresh air component of the air change is required to be minimum air changes out of total minimum 25 air changes. 2. Temperature and humidity. The temperature should be maintained at 21 plus, or minus 3 degrees Celsius inside the OT all the time with corresponding relative humidity between 40 to 60%, though the ideal RH is considered to be 55%. Housekeeping in hospital. Housekeeping in wards. A patient admitted to the hospital can develop infection due to bacteria that survive in the environment. Therefore, it is important to clean the environment thoroughly on a regular basis. This will reduce the bacterial load and make the environment unsuitable for growth of microorganisms. 1. The floor is to be cleaned at least twice in 24 hours. Detergent and copious amounts of water should be used during one cleaning. 2. The walls are to be washed with a brush, using detergent and water once a week. 3. High dusting is to be done with a wet mop. 4. Fans and lights are cleaned with soap and water once a month. 5. All work surfaces are to be disinfected by wiping with suitable disinfectant, supershine benzalkonium chloride, then cleaned with detergent and water twice a day. 6. Cupboards, shelves, beds, lockers, floor stands, stools and other fixtures are to be cleaned with detergent and water once a week. 7. Curtains are to be changed once a month or whenever soiled. These curtains are to be sent for regular laundering. In certain areas, for example, ICUs, more frequent changes are required. 8. Patient's cot is to be cleaned every week with detergent and water. 1% hypochlorite to be used when soiled with blood or body fluids. In the isolation ward, cleaning is done daily. 9. Storerooms are to be mopped once a day and high-dusted once a week. 10. The floor of bathrooms is to be cleaned with a broom and detergent once a day and then disinfected. 11. Toilets are cleaned with a brush using a detergent twice a day, in the morning and evening. Disinfection and stain removal solution may be used. 12. Wash basins are to be cleaned every morning. 13. Regular AC maintenance is required. The AC section should draw up a protocol for this. Miscellaneous items: kidney trays, basins, bedpans, urinals, etc. to be cleaned with detergent and water and disinfected with 7% Lysol. 2. Housekeeping in the operation theatre. Theatre complex should be absolutely clean at all items. Dust should not accumulate at any region in the theatre. Soap solution is recommended for cleaning floors and other surfaces. Operating rooms are cleaned daily and the entire theatre complex is cleaned thoroughly once a week. Before the start of the first case. Wipe all equipment, furniture, room lights, suction points, OT table, surgical light reflectors, other light fittings, slabs etc. with soap solution. This should be completed at least 1 hour before the start of surgery. Linen and gloves. Gather all soiled linen and towels in the receptacles provided. Take them to the service corridor, behind the theatre, and place them in trolleys to be taken for sorting. The dirty linen is then sent to the laundry. Use gloves while handling dirty linen. B. Instruments. Used instruments are cleaned immediately by the scrub nurse and the attender. Reusable sharps are decontaminated in Lysol or hypochlorite and then washed in the room adjacent to the respective OT by scrubbing with a brush, liquid soap and Vim. They are then sent for sterilization in the CSSD. After septic cases, the instruments are sent in the instrument for autoclaving. Once disinfected, they are taken back to the same instrument cleaning area for a manual wash described earlier. They are then packed and re-autoclaved before use. See environment. Wipe used equipment, furniture or table etc., with detergent and water. If there is a blood spill, disinfect with sodium hypochlorite before wiping. Empty and clean suction bottles and tubing with disinfectant. D. After the last case. The same procedures as mentioned above are followed, and in addition the following are carried out. Wipe overhead lights, cabinets, waste receptacles, equipment, furniture with disinfectant like rapid insider, foam insider etc. Wash floor and wet mop with liquid soap and then remove water and wet mop with super shine solution. Clean the storage shelves, scrub and clean room. Weekly cleaning procedure. Remove all portable equipment. Damp wipe lights and other fixtures with detergent. Clean doors, hinges, facings, glass inserts and rinse with a cloth moistened with detergent. Wipe down walls with clean cloth mop with detergent. Scrub floor using detergent and water or super shine. Stainless steel surfaces, clean with detergent, rinse and clean with warm water. Replace portable equipment, clean wheel casters by rolling across toweling saturated with detergent. Wash, clean, and dry all furniture and equipment, OT table, suction holders, foot and sitting stools, Mayo stands, 4 poles, basin stands, X-ray view boxes, hamper stands, all tables in the room, holes to oxygen tank, kick buckets and holder, and wall cupboards. After washing floors, allow disinfectant solution to remain on the floor for 5 minutes to ensure destruction of bacteria. 3. Protocol for body fluid splash and spillages. Blood and body fluid spillage. Prepare 1% hypochlorite solution, 200 ml 5% hypochlorite in 800 ml of water. Wear gloves. Pour 1% hypochlorite on the spillage. Cover it with a piece of paper or cloth. Keep it there for 10-20 minutes. Wipe the spillage using the covered paper or cloth. After wiping, discard the same in the yellow cover. If it is a large spillage, after covering the spillage with paper or cloth, mop it with separate mop. Mop should be dipped in 1% hypochlorite for 30 minutes. HIC 3. Hospital Infection Control Surveillance Activities. Methods of surveillance: fumigation and random culture from high-risk areas. HICC decided that culture swab to be taken from critical areas once in months or when an infection is suspected. Take the swabs according to the table shown below. The request of sample to be approved by the infection control nurse. The original copy of the culture report to be filed in the infection control department and a copy of the report to be filed in the concerned department as well. Surveillance culture schedule. 1. For all OT, do weekly surveillance, and monthly twice, on Sunday, surveillance culture, along with fumigation on every Sundays, weekly cleaning on every Sunday, and SOS and air culture every 6 months. Day before any major surgeries and any after infected cases notified. 2. For NICU, do monthly surveillance, and every month surveillance culture, along with fumigation twice a month, and SOS, cleaning every Sunday, and air culture once in a year. 3. For SICU, do monthly surveillance, and every month, and SOS surveillance culture, along with every month, and SOS fumigation, cleaning every Sunday, and air culture once in a year. 4. For ICU, do monthly surveillance, and every month, and SOS surveillance culture, along with monthly fumigation, cleaning on monthly basis, and air culture once in a year. 5. For casualty procedure room, MO, and every month surveillance culture, along every 3rd month fumigation, cleaning every Sunday, and air culture once in a year. 6. For CSSD, monthly surveillance culture, along with weekly fumigation. 7. For labor room, every month, and SOS surveillance culture, along with every month, and SOS fumigation. 8. For endoscopy, every month, and SOS surveillance culture, along with every month, and SOS fumigation. The collection of surveillance data is an ongoing process in hospital. The infection control team verifies the data on a regular basis. The surveillance activities in hospital also incorporates tracking and analyzing of infection risks, rates and trends. Monitoring activities includes. The surveillance activity include monitoring of compliance with hand hygiene guidelines. Surveillance activities in hospital also include monitoring of effectiveness of housekeeping service on a regular basis using a checklist. Report regarding high rates is informed to all the departments monthly wise. The hospital identifies all notifiable diseases and ensures that this is sent at the specified frequency and in format as required by statutory authorities. 1. Acute diarrheal disease. 2. Acute dysentery, amoebic and bacillary. 3. Acute flaccid paralysis. 4. Cholera or cholera-like disease. 5. Diphtheria. 6. Encephalitis. 7. Plague. 8. Hepatitis viral. 9. Leptospirosis. 10. Malaria. 11. Measles. 12. Meningitis. 13. Rabies. 14. Tetanus. 15. Enteric fever. 16. Pertussis. 17. Dengue. 18. Chickenpox. 19. Chikungunya. 20. H1N1, swine flu. 21. Others as and when there is new trends of sporadic, pandemic or endemic cases. HIC4, prevention and control of healthcare-associated infections, HAI, in patients. There are predominantly 4 types of hospital-acquired infections. They can be recorded on the basis of clinical and microbiological data. CORTI. Catheter-associated urinary tract infections. The urinary tract infections may be symptomatic, fever, dysuria, lumbar pain, or asymptomatic. Their recordings depend partly on the microbiological tests performed. VAPI. Ventilator-associated pulmonary infection or respiratory tract infections. Analyzing the respiratory tract infections through the following: ventilated days, fever, X-ray findings, neutropenia, SSI, surgical site infection or post-operative infections. Any surgical wound which results in a purulent discharge must be regarded as a hospital-acquired infections. Whether the bacteria are of endogenous or exogenous origin is not taken into the account. CLABSI. Central line-associated bloodstream infections. Inflammation, lymphangitis or purulent discharge at the insertion site of the central line catheter. The organization takes action to prevent urinary tract infections. Urethral catheterization. Personnel. Only persons who know the correct technique of aseptic insertion and maintenance of catheters should handle catheters. Catheter use. Urinary catheters should be inserted only when necessary and left in place only as long as medically indicated. Hand wash. Hand washing should be done immediately before and after any manipulation of the catheter site or apparatus. Catheter insertion. Catheters should be inserted using aseptic technique and sterile equipment. Use an appropriate antiseptic solution for periurethral cleaning. As small a catheter as possible, consistent with good drainage, should be used to minimize urethral trauma. Indwelling catheters should be properly secured after insertion to prevent movement and urethral traction. Anchoring the catheter. Strapping of the catheter is done to the lower anterior abdominal wall in male patients. This is to prevent direct transmission of the weight of the bag on the catheter, so that pulling and inadvertent dislodgement of the catheter does not occur. This also helps to prevent stricture of the penile urethra if the patient is on a catheter for a long duration. B. The hospital takes action to prevent respiratory tract infections. In addition to the general guidelines that are to be adhered to, the following should also be noted with regard to respiratory care. Mouth flora influences development of nosocomial pneumonia in ventilated patients. Frequent chlorhexidine mouthwashes minimize the chances of pneumonia. 1. Ventilator. Sterile water is to be used in nebulizers and humidifiers. This should be replaced once or twice a day. Pneumatic circuits, masks, Y connection and tubes are to be changed every 24 to 48 hours. Condensate in tubing should not be drained into the humidifier or airway as they contain large numbers of pathogenic organisms. This should be drained only into water traps. Use disposable circuits if cost permits. Use heat and moisture exchanging filter, HMEF, at Y connection for all patients if feasible and cost permits. Heat and moisture exchanging filter, HMEF, is to be changed every 24-48 hours. It should not be removed from circuit except at the time of changing. Oxygen masks, venture devices and nebulizer chambers are cleaned carefully and then sterilized by ETO. Humidifier domes are ETO sterilized. Ambu bags are cleaned thoroughly and are then sent for ETO sterilization. Microbiological surveillance of respiratory therapy equipment is practiced in our hospital. 2. Tracheostomy care and endotracheal tube. Careful attention to post-operative wound care is mandatory. The patient should receive aerosol therapy to prevent desiccation of the tracheal and bronchial mucosa or the formation of crusts. The skin around the tracheostomy tube should be cleaned with betadine, povidone iodine 5%, every 4 hours or more frequently, if necessary. In case of metal tracheostomy tubes, the inner cannula should be cleaned every 4 hours and more often if necessary to prevent the formation of crusts. The inner cannula is cleaned with water, immersed in hydrogen peroxide for 15 minutes and then rinsed with fresh and sterile normal saline. The plastic tracheostomy tubes are removed, another plastic tube is inserted, and the tube is cleaned with hydrogen peroxide and rinsed well before reuse. The tracheostomy tube should be changed every 24 hours. This tube must be tied securely at all times. The first complete tube change should be performed not earlier than 4 to 5 days to allow time for the tract to be formed. Subsequent changes should be done weekly or as necessary. Clean technique should be used to change the tracheostomy tube unless there is a medical indication for sterile technique. The obturator should be at the bedside, preferably taped to the head of the bed, to be used if the tracheostomy tube accidentally is dislodged or is removed for any reason. 3. Suctioning of endotracheal or tracheostomy tube. Employees should be instructed and supervised by trained personnel in proper technique before performing this procedure on their own. Assess the patient using auscultation, ECG, if available, and vital signs prior to suctioning. A. Sterile suctioning steps. 1. Wash your hands with soap to perform the procedure. 2. Attach the suction catheter to the suction tubing. 3. Put on sterile gloves. The wearing of a mask is also strongly recommended. 4. If on a respirator, pre-oxygenate the patient by connecting the resuscitation bag to the artificial airway and ventilating the patient with 3 or 4 deep breaths. A mechanical ventilator on 100% oxygen may also be used by depressing the manual ventilation button 3 or 4 times. 5. Insert the catheter gently through the inner cannula until resistance is met. Do not apply suction during insertion. 6. Withdraw the catheter approximately 1 cm and institute suctioning. 7. Carefully withdraw the catheter, rotating it gently between the thumb and forefinger, applying intermittent suctioning. 8. When suctioning is completed, clear the catheter and tubing of mucus and debris with sterile water or saline. 9. Discard the catheter, water container, and gloves appropriately. 10. Perform hand washing with soap and water after the procedure. B. Precautions. 1. Use a catheter with a blunt tip. 2. The wall suction should be set no higher than 120 mm Hg for adults and between 60 and 80 mm Hg for children. 3. Do not touch the catheter with bare hands, leave it in its protective covering. 4. If saline does need to be instilled, a half cc of sterile saline is put into the tracheostomy tube on inspiration only. 5. A mechanical ventilator on 100% oxygen may also be used by depressing the manual ventilation button 3 or 4 times. For pre-oxygenation. 6. Withdraw the catheter approximately 1 cm before institute suctioning. 7. Continuous suctioning for longer than 10 seconds may create an unacceptable level of hypoxia. 8. The patient should be given time to rest between suctioning episodes. If possible, This time should be from 2 to 3 minutes. 9. If the patient is receiving oxygen or ventilator support, reapply the oxygen or ventilator for at least 2 minutes before resuctioning. 10. Observe for unfavorable reactions such as increased heart rate, hypoxia, arrhythmia, hypertension, cardiac arrest, etc. 11. If oral suctioning is necessary, it should be done after the tracheostomy is suctioned. 12. When suctioning is completed, clear the catheter and tubing of mucus and debris with sterile water or saline. 13. The tubing and suction canister should be changed every 24 hours. 14. The canister should be labeled with the date and time when they are changed. 15. If debris adheres to the side of the tubing or the canister, either or both should be changed. 16. The tubing should be secured between suctioning periods so that it will not fall to the bed, floor, etc. C. The hospital has taken action to prevent intravascular device infection. I. Hand washing. Wash hands before every attempted intravascular cannula insertion. Antimicrobial hand washing soaps are desirable, and are preferred before attempted insertions of central intravenous catheters, catheters requiring cut-downs, and arterial catheters. 2. Preparation of skin. Povidone iodine, PVP, or 70% alcohol may be used for cleaning the skin. Insertion sites should be scrubbed with a generous amount of antiseptic. Beginning at the center of the insertion site, use a circular motion and move outward. Antiseptics should have a contact time of at least 30 seconds prior to catheter insertion. Antiseptics should not be wiped off with alcohol prior to catheter insertion. 3. Applying dressings. Sterile dressings should be applied to cover catheter insertion sites. Unsterile adhesive tape should not be placed in direct contact with the catheter skin interface. 4. Record time and date of IV insertion. V. Inspecting catheter insertion sites. Intravascular catheters should be inspected daily and whenever patients have unexplained fever or complaints of pain, tenderness, or drainage at the site for evidence of catheter-related complications. 6. Inspect for signs of infection. Redness, swelling, drainage, tenderness, or phlebitis, and also palpate gently through intact dressings. 7. Manipulation of intravascular catheter systems. Strict aseptic technique should be maintained when manipulating intravascular catheter systems. Examples of such manipulations include the following: placing a heparin lock, starting and stopping an infusion, changing an intravascular catheter site dressing, changing an intravascular administration set, flushing IV lines. Solutions used for flushing IV lines should not contain glucose, which can support the growth of microorganisms. Do not reuse syringes used for flushing. One syringe is used for flushing only one IV line once. A. Peripheral foresights, short-term catheters. Dressing changes. Peripheral IV site dressings should not usually require routine changes, since peripheral IV catheters should be removed within 72 hours. Replacement of peripheral fore catheters. Peripheral IV catheters should be removed 72 hours after insertion, provided no IV-related complications requiring catheter removal are encountered earlier. A new peripheral fore catheter, if required, may be inserted at a new site. B. Central intravascular catheters, long-term catheters. Dressing changes. Central IV catheter dressings should be changed every 72 hours. Replacement central IV catheters do not require routine removal and reinsertion. The catheter can be kept for a maximum of 3 months, provided there is no sign of catheter-related infection or other complications. Catheter-related infection. At the time of catheter removal, the site is examined for the presence of swelling, erythema, increased tenderness and palpable venous thrombosis. Any antimicrobial ointment or blood present on the skin around the catheter is first removed with alcohol. The catheter is withdrawn with sterile forceps, the externalized portion being kept directed upward and away from the skin surface. If infection is suspected, after removal, the wound is milked in an attempt to express purulence. For 5.7 cm catheters, the entire length, beginning several millimeters inside the former skin surface catheter interface, is aseptically cut and sent for culture. With longer catheter, 20.3 cm and 60.9 cm in length, 5 to 7 cm segments are cultured proximal one beginning several millimeters inside the former skin catheter interface and the tip. Catheter segments are transported to the laboratory in a sterile container. 3-way with extension is used only when multiple simultaneous infusion or central venous pressure monitoring are required. All invasive procedures are recorded in a book. Please keep a register for this in nursing areas. D. The organization takes action to prevent surgical site infections. Surgical wounds. Surgical wounds after an elective surgery are inspected on the 3rd post-operative day, or earlier. All personnel doing dressings should wash their hands before the procedure. Ideally, a 2-member technique is followed. 1 to open the wound, and 1 to do the dressing. If 2 healthcare workers are not available, then, take off the dressing, wash hands again before applying a new dressing. A clean, dry wound may be left open without any dressing after inspection. If there is any evidence of wound infection, or purulent discharge, then dressings are done daily, using povidone iodine to clean the wound and applying dry absorbent dressings. If any surgical site infection occur, surgical site infection reporting format is filled up by surgeons. Records maintained by registrar in charge. Data collected every quarterly by Secretary Hick and presented. Special studies will be conducted as needed. These may include the investigation of clusters of infections above expected levels, the investigation of single cases of unusual or epidemiologically significant nosocomial infections, prevalence and incidence studies, collection of routine or special data as needed and sampling of personnel or the environment as needed. Injection abscess. Calculation of total HAI. A percentage is calculated based on the detected number of HAI and the total number of long-stay patients in the hospital. Calculation of device-associated infection rate. Device-associated infection rate is calculated by dividing number of device-associated infections for a specific site by device days and then multiplicating it with 1000 number of device days. Where calculation of numerator is done summing up all of the isolates from lab and device samples. And calculation of denominator is done by counting total number of days of exposure to device by all of the patients in a given month. For this, note down the number of patients exposed to the device on each day of the month. The total is the denominator. This is done for 3 devices, namely central line, sample from CVP tip, ventilator sample from endotracheal tube secretions, Foley's catheter, urine sample. HIC5, Resources for Prevention and Control Healthcare-Associated Infections. Hospital provides adequate and appropriate personal protective equipment for employees, soaps and disinfectant at the point of use, and adequate inventory is maintained at all time to ensure availability of these. Personal protective equipments includes gloves, protective eyewear, mask, apron, gown, boots, shoe covers, cap, hair cover. The hospital have adequate and appropriate facilities for hand hygiene in all patient care areas such as liquid hand wash, large wash basin with elbow-operated taps, tissue paper, hand dryer, hand rubs etc. are available to all healthcare providers. A. The hospital defines the conditions where isolation, barrier nursing or both isolation and barrier nursing is required. The organization provides barrier nursing facilities such as clothing, mask, gloves, etc. Isolation protocols. Definition: it is the separation of infected persons from the non-infected persons for the period of communicability under conditions which will prevent the transmission of infection. When a patient comes with any infectious disease or immunocompromised state, the concerned ward staff will inform the ICN and she will arrange the room, or if the patient is critically ill, admit the patient inside bed allocated for isolation patients of the concerned ICU. Strict isolation. Strict isolation is an isolation category designed to prevent transmission of highly contagious or virulent infections that may be spread by both air and contact. Specification for strict isolation. 1 private room is indicated, door should be kept closed. 2 masks, gowns and gloves are indicated for everyone entering the room. Contact isolation. A. Contact isolation is designed to prevent transmission of highly transmissible or epidemiologically important infections, or colonization that do not warrant strict isolation. B. All diseases or conditions included in this category are spread primarily by close direct contact. Specification for contact isolation. 1 private room is indicated. 2 masks are indicated for those who come close to the client. 3 gowns are indicated if soiling is likely. 4 gloves are indicated for touching infective material. 1 respiratory isolation. Respiratory isolation is designed to prevent transmission of infectious diseases primarily over short distances through the air, droplet transmission. Specifications for respiratory isolation. 1 private room is indicated. 2 masks are indicated for those who come close to the client. 3 gowns are not indicated. 4 gloves are indicated if contamination of hands is anticipated. 2 tuberculosis isolation, AFB isolation. Tuberculosis isolation, AFB isolation, is an isolation category for clients with pulmonary tuberculosis who have a positive sputum smear or a chest film that strongly suggests current, active, tuberculosis. Laryngeal tuberculosis is also included in this isolation category. Specification for tuberculosis isolation, AFB isolation. 1 private room with special ventilation is preferred, door should be kept closed. 2 masks are indicated only if the client is coughing and does not reliably cover mouth. 3 gowns are indicated only if needed to prevent cross-contamination of clothing. 4 gloves are indicated if contamination of hands is anticipated. 3 enteric isolation. Enteric precautions are designed to prevent infections that are transmitted by direct or indirect contact with feces. Specification for enteric precautions. 1 private room is indicated if client's hygiene is poor. 2 masks are not indicated. 3 gowns are indicated if soiling is likely. 4 gloves are indicated for touching infective material. Protocol for receiving patient with dengue and chikungunya, lepto, malaria. 1 Receive the patient in isolation room or ward. 2 Inform infection control nurse. 3 Confirm report from laboratory. 4. Provide isolation measures with facilities of mosquito net, mosquito repellent. 5. Send notification card to infection control nurse. 6. Infection control nurse will inform to DMO Health by telephone and then send notification through email to DMO. 7. Instruct the relatives to protect themselves and others by keeping the environment free from mosquito. Drainage and secretion precautions. Body substance isolation. Drainage and secretion precautions are designed to prevent infections that are transmitted by direct or indirect contact with purulent material or drainage from an infected body site. Specification for drainage and secretion precautions. 1. Masks are not indicated. 2. Gowns are indicated if soiling is likely. 3. Gloves are indicated for touching infective material. Disease requiring drainage and secretion precautions. The following infections are examples of those included in this category provided they are not 1. Caused by multiple resistant microorganisms. 2. Major draining, not covered by a dressing or does not adequately contain the drainage, skin wound, or burn infections, including those caused by Staphylococcus aureus or group of Streptococcus. 3. Gonococcal eye infections in newborns. See contact isolation if the infection is one of these. Abscess, minor limited. Burn infection, minor limited. Conjunctivitis. Decubitus ulcer, infected, minor or limited. Skin infection, minor or limited. Wound infection, minor or limited. Blood-body fluid isolation. This type is designed to protect the caregiver from getting infected by the disease. 1. Specifications for blood and body fluid isolation. A. Private room required only if the person's hygiene is poor. B. Use of mask is indicated if the client is suffering from other infections, for example active tuberculosis, pneumonia, etc. C. Gowns are indicated if spoilage with blood and body fluids is likely. D. Gloves are indicated for touching blood and body fluids. E. Wash hands immediately if potentially contaminated by blood or body fluids. 2. Disease conditions requiring blood and body fluid isolation. A. Acquired immune deficiency syndrome. B. Creutzfeldt-Jakob disease. C. Hepatitis B, and Psig carrier. D. Hepatitis C. E. Hepatitis non-A, non-B. The following points are common for all the types of isolation. A. Hands must be washed after touching the client or potentially contaminated articles and before taking care of any other client. B. Stick biohazard symbol on the contaminated articles before sending to the CSSD. C. Discard all infectious wastes non-plastic in yellow plastic bag. MRSA Protocol. 1. Admission to an isolation room. 2. Single-use disposable plastic apron should be worn for patient contact. 3. The gown or plastic apron and gloves should be removed before leaving the room. 4. Single-use disposable gloves should be worn for handling contaminated tissue, dressing or linen. 5. Hands must be decontaminated after removing the gloves. 6. High-efficiency filter-type masks should be used for procedures that may generate aerosols. 6. Bed linen and clothing should be changed daily. 7. Linen bags must be sealed at the bedside and removed directly to the dirty utility area or the collection point. 8. All instruments used for the patient care must be kept with the patient. 9. Use dedicated equipments. 10. Hand must be washed before and after contact with the patient or their environment. Use chlorhexidine or alcoholic-based hand rub. 11. All single-use items must be disposed of as clinical waste. Clinical waste bags must be sealed before leaving the room. All reusable items would be processed in accordance with the local disinfection policy. Pre- and post-exposure prophylaxis. The hospital provides hepatitis B vaccination for all staff as a part of pre-exposure prophylaxis, managing exposure to potentially infectious body fluid. Categories of exposure: A. Needle stick injuries. B. Non-intact skin exposure. C. Mucosal exposure, for example, splash into eye. Immediate action to be taken: 1. Wash in running water. 2. Non-intact skin exposure, wash for 10 minutes with soap and water. Report to infection control nurse. 3. Mucosal exposure, for example, splash into eyes, wash for 10 minutes by using clean water or normal saline to irrigate the eye. The eyelid should be held open by another person wearing sterile gloves. Do not use soap and water or disinfectant. Needle stick injury, post-exposure prophylaxis. I. Do not squeeze. 2. Wash hand in running water with soap. 3. Inform infection control nurse. 4. If housekeeping staff injured, inform housekeeping supervisor. Steps protocol, manual. 1. Check status of the injured staff. 2. Status of the source. 3. Inform the consultant. 4. Inform patient, check patient's serology. Step 1. If patient's serology hepatitis B positive, known case of hepatitis B positive. Check vaccination status of injured person. If vaccinated, check HB3A3 titer. If not vaccinated, provide hepatitis B vaccine. If patient is positive case, check HBsAg titer. If HBsAg titer value 10, provide immunoglobulin within 24 hours. Step 2. If patient known case of HIV positive or unknown and staff is injured. 1. Consult concerned physician. 2. Start antiretroviral therapy, ART, as early as possible. 3. If patient is HCV positive, hand washing in running water with soap. 4. Consult concerned physician. After post-exposure of known case of hepatitis B, HIV and HCV or unknown. Follow up the serology of staff for 3 months, 6 months and 12 months. Infection control nurse to monitor, follow up and maintain documents. HIC 6. Control of outbreaks of infections. Hospital documents the procedures for identifying and managing an outbreak. Procedure to identify an outbreak. The occurrence of 2 or more similar cases relating to place and time is identified as a cluster or an outbreak and needs investigation to discover the route of transmission of infection, and possible sources of infection in order to apply measures to prevent further spread. If the cases occur in steadily increasing numbers and are separated by an interval approximating the incubation period, the spread of the disease is probably due to person-to-person spread. On the other hand, if a large number of cases occur following a shared exposure, for example an operation, it is termed a common source outbreak, implying a common source for the occurrence of the disease. Investigation of an outbreak. Epidemiological methods. The investigation of an outbreak may require expert epidemiological advice on procedures. Formulation of a hypothesis regarding source and spread is made before undertaking microbiological investigations in order that the most appropriate specimens are collected. Steps to be taken to investigation an outbreak. Step 1. Recognition of the outbreak. Is there an increase in the number of cases of a particular infection or a rise in prevalence of an organism? Such findings indicate a possible outbreak. Preliminary investigation must be begun by developing a case definition, identifying the site, pathogen and affected population. Determination of the magnitude of the problem and if immediate control measures are required. If so, general control measures such as isolation or cohorting of infected cases, strict hand washing and asepsis should be immediately applied. Verification of the diagnosis. Each case should be reviewed to meet the definition. Confirmation that an outbreak exists by comparing the present rate of occurrence with the endemic rate should be made. B. Step 2. The appropriate departments and personnel and the hospital administration should be notified and involved. C. Step 3. Additional cases must be searched for by examining the clinical and microbiological records. Line listings for every case, patient details, place and time of occurrence and infection details should be developed. An epidemic curve based on place and time of occurrence should be developed, the date analyzed, the common features of the cases like age, sex, exposure to various risk factors, underlying diseases etc. should be identified. A hypothesis based on literature search and the features common to the cases should be formulated to arrive at a hypothesis about suspected causes of the outbreak. Microbiological investigations depending upon the suspected epidemiology of the causative organism should be carried out. This will include a. Microbial culture of cases, carriers and environments. B. Epidemiological typing of the isolates to identify clonal relatedness. The hypothesis should be tested by reviewing additional cases in a case control study, cohort study, and microbiological study. D. Step 4. Specific control measures should be implemented as soon as the cause of outbreak is identified. Monitoring for further cases and effectiveness of control measures should be done. A report should be prepared for presentation to the HICC, departments involved in the outbreak and administration. The hospital takes appropriate corrective action to prevent the recurrence. Immediate control measures. Control measures should be initiated during the process of investigation. An intensive review of infection control measures should be made and general control measures initiated at once. General measures include strict hand washing, intensification of environmental cleaning and hygiene, adherence to aseptic protocols, and strengthening of disinfection and sterilization. Microbiological study. Microbiological study is planned depending upon the known epidemiology of the infection problem. The study is carried out to identify possible sources and routes of transmission. The investigation may include cultures from other body sites of the patient, other patients, staff and environment. Careful selection of specimens to be cultured is essential to obtain meaningful data. Specific control measures. Specific control measures are instituted on the basis of nature of agent and characteristics of the high-risk group and the possible sources. These measures may include identification and elimination of the contaminated product, modification of nursing procedures, identification and treatment of carriers, and rectification of lapse in technique or procedure. Evaluation of efficacy of control measures. The efficacy of control measures should be evaluated by a continued follow-up of cases after the outbreak clinically as well as microbiologically. Control measures are effective if cases cease to occur or return to the endemic level. The outbreak should be documented. Handling of biomedical waste, BMW, HIC 7. The organization adheres to statutory provisions with regard to biomedical waste. Waste management policy at the hospital has been implemented in accordance with the rules of Biomedical Waste Management Act. The hospital has got the consent to operate under Pollution Control Board. The hospital adopts color-coded segregation of biomedical waste in all patient care areas. This is monitored by HIC team on daily basis. All waste containers are emptied when they are 3/4 full. Segregation is done at source. A color code is followed and appropriately coded waste bags are placed in bins in all patient care areas. Segregated biomedical waste is stored and transported to the central waste collection area of the hospital in proper covered containers in secured manner. Waste from various patient care areas is removed twice a day or more if necessary. All bags that are being transported to the central waste collection area will have to be tied at the mouth to avoid spillage during transport. Smaller bags are collected into larger bags and carried by the on-duty housekeeping staff to designated storage areas on trolleys. Waste from various patient care areas is removed twice a day or more if necessary. Bags should be picked up and then transported before become completely full. Avoid the transport of too many bags at one time and contact of the bag with the body of personnel. Avoid mixing of segregated wastes. The staff is provided with personal protective equipment, PPE. Disposal of contaminated needles and syringes. Contaminated needles are destroyed using a needle destroyer. Contaminated fixed needle syringes are put in puncture-proof container, white. At segregation, syringes are put in red color-coded plastic bin. Biomedical waste treatment facility. The hospital has tie-up with authorized common waste management facility. The waste is collected from the collection area of hospital by approved vendor workers and transported in a covered vehicle to the treatment facility of the vendor. The local pollution control department conducts periodic visit to common waste management facility to ensure waste disposal according to BMW rules. Annual report of waste generated is maintained by administration and report submitted to Pollution Control Board. All categories of staff handling biomedical waste are using appropriate personal protective measures. Types of waste and treatment. There are 3 types of color-coded waste generated in a hospital: yellow, red, and blue, which is further subdivided according to the types and size of sharps. Yellow. Collected into yellow-colored non-chlorinated plastic bag. A. Human anatomical waste, human tissues, organs, body parts. B. Animal anatomical waste, animal tissues, organs, body parts. C. Soiled waste, items contaminated with blood, body fluids like dressings, plaster casts, and cotton swabs, blood bags. D. Discarded linen, mattresses, beddings contaminated with blood or body fluid. E. Microbiology, biotechnology and other clinical laboratory waste, laboratory culture plates, dishes and devices. F. Expired or discarded medicines. G. Chemical waste, chemicals used in production of biological and used or discarded disinfectants. H. Chemical liquid waste, liquid waste generated due to discarded disinfectants, discarded formalin, infected secretions, aspirated body fluids, liquid from labs, floor washings, cleaning, housekeeping and disinfecting activities, etc. Human and animal anatomical waste, microbiological waste, soiled incinerable waste of linen, cotton, gauge paces and plasters to be handed over to Biomedical Waste Collection Agency. Discarded and expired medicine can either be handed over to Waste Collection Agency or returned back to manufacturer. In case of chemical waste, it should be treated for 20 minutes with 1% sodium hypochlorite solution and discarded into drainage system. Red. Collected into red-colored non-chlorinated plastic bags or containers. Contaminated waste, recyclable. A. disposable plastic items like tubing, bottles, intravenous tubes and sets, catheters, urine bags, syringes, without needles and fixed needle syringes, and vacutainers with their needles cut, and gloves. Hand over to Waste Collection Agency. White. Collected into white, translucent, puncture-proof, leak-proof, tamper-proof containers. Waste sharps including metals, needles, syringes with fixed needles, needles from needle tip cutter or burner, scalpels, blades, or any other contaminated sharp object that may cause puncture and cuts. This includes both used, discarded and contaminated metal sharps. Please hand over to Waste Collection Agency for proper disposal. Blue cardboard boxes. With blue-colored marking and LAV equals belling. A. Glassware, broken or discarded and contaminated glass including medicine vials and ampoules except those contaminated with cytotoxic wastes. Time of collection of biomedical waste and packaging and labeling. Biomedical waste is collected at least once in a day or twice a day depending on quantity of waste generated and fullness of waste bins. It may be collected on need basis as well if required, as the waste bin bags should not be overfilled before collecting to avoid spillage. Bins are emptied before these are 3/4 filled. Plastic bags are never stapled, these are tied. Replacement bags installed in the bins and small bags are put into larger bags of same color and transported in covered trolleys covered and labeled as biohazard along with symbol for the same. In-house transportation of biomedical waste. In-house transportation of biomedical waste from site of waste generation, interim storage to central waste collection center, within the premises of the hospital is done in closed trolleys or containers fitted with wheels for easy maneuverability. Such trolleys or carts are designated for the purpose of biomedical waste collection only. Generated from different wards or laboratories in the healthcare facilities must be transported in the covered trolleys or carts through a route which has low traffic flow of patients and visitors. Central waste collection room for biomedical waste. Hospital has a designated central waste collection room situated within its premises for storage of biomedical waste, till the waste is picked and transported for treatment and disposal at CBWTF. This room is under the responsibility of a designated person and is always under lock and key. Maintenance of records. 1. Every authorized person shall maintain records related to the generation, collection, reception, storage, transportation, treatment, disposal and/or any form of handling of biomedical waste in accordance with these rules and any guidelines issued. 2. All records shall be subject to inspection and verification by the prescribed authority at any time. HIC 8. Infection Control Program Support, Training and Employee Health. The management makes available resources required for the infection control program. The hospital management ensures the availability of resources required for the infection control program. The hospital conducts induction training for all newly joined staff as and when required. Induction training includes policies, procedures and practice of infection control program. All categories of staff undergoes induction training and the records are maintained. The hospital conducts in-service training for all staff as per the training schedule. The frequency of training decided by the hospital based on the priority of the topic.